Thank you. Thank you for presenting such a comprehensive program. Uh, Next, we have Dr. Ming, who's from Fred Hollow Foundation in Australia, who's been working on refractive errors and quality of eye care services and research along that in the region.
Thank you, Shalinda. Namaste, everyone. Good morning. So what I'm going to be talking about is the quality of cataract surgery and the data collection for quality improvement. So it's the quality of the data that we're collecting. I'd like to acknowledge the medical team at the Fred Hollows Foundation, Dr. Leela Puri, who is also in the audience, Dr. Yanene, Rasheen, and Dilshad. So we've all heard about the effective cataract surgical coverage, which looks at the quality of cataract surgery. The Fred Hollows Foundation initiated a cataract quality improvement program, which was described by Amanda, which is based on the Institute of Health Improvements quality improvement methodology, which was also something that Aravind uses and described very clearly by Dr. Yasune-san. So some of the things that we've started doing at the foundation is implementing serious untoward incident reporting, setting minimum standards for cataract surgery, and we've also used CQI methodology, so the training for program staff and partners on quality improvement. And we've also trained a group of quality champions within the Fred Hollows Foundation. And we've also started to request partner submission of cataract surgical outcomes annually. So what we've asked them to do is for the cataract surgical institution partners to share the outcomes of 100 consecutive cases of surgery, excluding comorbidities, so that we can calculate the cataract surgical outcomes. So for adults over the age of 18, okay? And the data was collected by the quality champions based on the monitoring of cataract surgical outcomes template. So some of you might be familiar with that MCSO template. And then we collect the data, we analyze it, and we share it back with the partners. And this information actually forms the basis of quality improvement activities to be undertaken. So actually, a lot of our partners collect data, but they don't analyze the data. They don't look at it. So the data collection template looks complicated here, but it's actually basically looking at the demographics, visual acuity, pre-day 1, week 1 to 2, and weeks 4 to 6. And we look at unaided pinhole visual acuity or best corrected visual acuity. And we also look at the surgical location. So whether the surgeries were reported were done at hospital or outreach. And some surgical data as well, like which eye was operated, what was the predicted IOL power, and what was the actual IOL power implanted, and what surgical method did they use? Did they do small incision cataract surgery, or did they do phaco, and to report any complications? And also, if there were poor outcomes, what the causes of poor outcomes were. So we've trained so far 25 quality champions, and they all support partner institution in quality improvement activities, and they collect the CSOM data. This is across 16 countries across Asia and Africa. We managed to collect data from 14 countries. One of the countries that we didn't get any data from was Palestine, and I think that's for reasons that are quite obvious. I was able to analyze data from 13 countries because one of the partners reported, I think, 1,800 data points or data for 1,800 cases, but in a format that was very, very difficult to analyze unless we clean the whole data, which would have taken a long time. So I haven't done that one yet. So this came from 53 institutions, and one of the data sets shared was a national data set. So this national data set was quite interesting. So they had collected pre, intra, and post cataract surgical data, but they were in 3 separate files. So they have never actually tried to line up all 3 files to see a patient continue through the whole process. So we did that. And so they were not able to analyze it because they never actually did it. So it was national data that had 7,000 patients that they shared with us for the whole year. So from the data, I analyzed about 49 institutions that had more than 50 patients reported. So some of them sort of didn't get the 100 patients for the reporting period. And they range from 89 to 4,300. So with the 7,000 data points, we were able to get continuous data for about 4,300 patients. And the median was around 108. So, and that is in line with what we requested, which was 100 patients. 3 institutions reported data at 618 only, because that's what they were still using the old WHO cutoff for good outcomes. 46 institutions had full visual acuity capture, which means they reported visual acuity, because some people just reported good outcome or bad outcome, like in categories. So we don't know exactly what it was. And 4 countries only shared CSOM, but no data because of privacy laws within the countries. So that was fine. So I think you're all familiar with the definitions for outcomes of cataract surgery. So good is 612 or better for 80% of cases at presenting. Suboptimal between 612 and 660. So you want that to be less than 15%, and then poor less than 660. So you want that to be less than 5%. And with best correction, it's going to be a bit higher than that. So the outcomes, with 612 visual acuity, so we had 46 institutions. So you can see the number of institutions that we were able to collect the data for presenting visual acuity, pinhole visual acuity. So presenting visual acuity, we had 36 people reporting, 36 institutions, and then only 17 of them did pinhole. So a lot of people were just doing presenting visual acuity and not reporting pinhole. And you can see that across from weeks 1 to 2 and 4 to 6. So you can also see that the numbers start to decline. So initially we had 36, then we had 33, and then it dropped down to 30. But this is only showing the number of institutions reporting. It doesn't show the number of patients. So most people will have the day 1 data, and then by week 1 or 2, the numbers of patients has actually dropped by about 10, 20%, sometimes 30%. And then 4 to 6, we're looking at less than 50% of the patients coming back. And for the institutions that reported 618, 3 of them presenting visual acuity were all better than 80%. So for poor outcomes, so this is also important because we want less than 5%. So it was 0 to 26% with a median of 2%, and the average was about 4.6%. So it showed that there was some institutions that were getting quite high percentages of poor outcomes. And I suspect that this is not because of the skills of the surgeon or something going wrong, but I think some of them had comorbidities in there, which they did not record. Yep, so for the 17 institutions that we had data for 612 and 618 and day 1 and week 1 to 2 data. So you can see the average good outcomes with presenting visual acuity at 612 was about 26.5%. That increases to 47% at 618. And then at weeks 1 to 2, at 612, that's increased to 41%, as you would expect. The longer it is, the better the outcome. And at 618, that was about 63%. So what was the challenges? I already said, non-uniform reporting. So initially, we thought we do not want to increase the burden on the hospitals. Everyone's busy. We will say, okay, these are the minimum data sets that we want, the data that we need. You report it to us using your templates, whatever. So we ended up not getting a lot of information. Measurement and recording of visual acuity. Sometimes people were recording it in quite non-standard ways. So then we had to sit there and try and figure out what was going on. Follow-up visit data, which previous speakers have already spoken about. It was very difficult to get the data. There's a lack of national standards or indicators, and I've mentioned the comorbidities. So this one is an example of one of the sheets we got back. So it was not even written in a language that we could easily decipher. And this meant that we also had to try and decipher it and then do the data entry ourselves. So I'd like to finish by giving a case study of how we actually have used this data. So this partner, they reported 154 patients, 108 females, 46 males, and you can see the average age and the entry visual acuity. So most of them were moderate vision impairment and to severe and blind. So that was about 90, that formed about, 97% of the patients or 99% of the patients. So the reason we did this with this partner was to go through the process that Dr. Yasune-san described. We wanted to find out what the cataract surgical outcomes were, and then we were going to do a quality improvement project with them to map out the whole thing. And they had no idea what the cataract surgical outcomes was. So they, oops. It's time. Sorry. So okay, I'll go through this very quickly. So at good visual acuity, at 4 to 6 weeks, so they got 154. All patients turned up for their 4 to 6 weeks because they wanted to collect this data set so that they could do CQI. So with good outcomes, so it was 15% at 4 to 6 weeks. And then if you look at the male and the female outcome, there was a significant difference. And then if we look at the old standards at 618, it was 62%. So most of their patients were actually having visual acuity of 615 to 618. So that's not too bad. Like to elevate that to 612, that's not going to be too bad. But it was quite eye-opening for them because when they initially said, we need to improve our cataract surgical outcomes from A to B, they thought their A was 70%. Right? Without having any analysis. And I'll tell you why. Because in this country, the national standard, so the standard threshold to be achieved is over 80%. And good visual acuity definition is 2 lines better than pre-surgical. Okay, so we all know that if you go in blind, 2 lines better, you could still be blind or severely vision impaired. And so if we looked at their data for cases of pre-op VA of 660 or better, there were 83 patients. At week 1 to 2, 92% of their patients had that outcome. At week 4 to 6, 95% of their patients. So, so this was actually quite an interesting exercise. So then, we will be using this, and then we will be trying to advocate to that government to adopt the international standards for good cataract surgical outcomes. So what lesson did we learn? The use of we can use data collected to motivate better data collection. If we show them, okay, if you collected pinhole or best corrected visual acuity for your patients, we could tell you how many patients, what is the percentage of patients you could have improved if you just gave them glasses afterwards. But if you only gave us presenting, we don't know what the patient's final outcome could have been. We demonstrated how they could use the data. And so now we're going to implement a standardized reporting format. So we're going to work with our team to create some sort of a simple spreadsheet that they can fill in and be very prescriptive about what data we want to collect. And so also to improve communication through our quality champions and partners. And that's it from me. Thank you.